afternoon. Welcome to AETCM, the YouTube channel for the emergency medicine. Today we are going to discuss a topic of a nasal bleed, that is epistaxis.
Okay.
We received a patient, a 62-year-old female, with complaints of nasal bleeding. Right now, the first initial 10-second assessment, patient was able to speak in one full sentence. Circulation-wise, the patient appears normal color, and disability-wise, patient is fully conscious and oriented.
Okay.
Now coming to the primary survey. In the airway, patient was able to talk in one full sentence. There was no any collection of the secretions or any fallen tongue or foreign body in the throat, ma'am. And breathing wise, patient was having respiratory rate of 18 per minute, saturation 99%, and chest was bilaterally moving, no any external muscles effort, and bilateral air entry equal was present, ma'am. Now, circulation wise, patient's skin color looks normal, peripheral pulses are palpable, and there was active bleeding from the nose. At present, the patient is bleeding from the right nostril. Ma'am.
Okay.
Heart rate was 110 per minute, and blood pressure was 220 by 120 mm of Hg.
Okay.
Epistaxis was present. As there was bleeding, immediate intervention was done by giving a gauze soaked with tranexamic acid and was asked to pinch the nose, and the patient was advised to slightly lean forward. The Trotter's method was advised at this point.
Okay. So we have a patient with bleeding from right nostril.
Yes,
Okay.
ma'am.
So right nostril bleeding. Where are the areas where the bleeding occurs in the nose nasal
In
cavity?
the nose, it can be like the anterior side or the posterior
What
side.
is the anterior side?
Anterior is the little plexus, little plexus.
That is a little area.
Little area.
And there what plexus is there?
Kesselback
Plexus are there.
Yes.
Or if it is posterior?
Woodruff's plexus.
Woodruff's plexus. Okay. So in Kesselback plexus, many arteries are coming. Woodruff's plexus is
only majorly posterior ethmoidal artery and the sphenoid
mainly sphenopalatine artery. So how will we know with the patient presentation where the bleeding is?
Depending upon where he is complaining, if the blood is spurting out of the nose, most likely it would be the anterior bleed. If he is having post-nasal dripping present, it might be a posterior.
Okay. So we have anterior and posterior.
Yes.
Okay. So we have anterior and posterior. So it is from Little's area. Little's area, and this is from the Woodruff's plexus. Okay. And anterior will be ipsilateral. One side bleeding will be there. But this will be mostly bilateral. Okay. And this is more profuse. It's more profuse. Another thing is patient might be, since it is posterior, patient might be having like post-nasal drip like that, bleeding will be there, and bleeding
collection of the secretions in the
will be there, and the bleeding will be coming through the mouth also. So that is how we can differentiate. Okay. Another thing is that this patient is having tachycardia and high BP. Okay. Suppose this patient's heart rate is 110 and BP is only 120/80. What should we suspect?
We should be suspecting if there is any impending shock, hypotension.
Okay. So suppose patient's heart rate is this much and BP is this much. What classification of shock patient will be?
Second
class will be there. So okay. So but in this patient BP is very high. What might be the cause of high BP?
Usually in epistaxis, majorly high BP can be cause of the epistaxis, but there should be any source of provocative action which is causing the bleed, either by nose picking or a heavy sneeze or anything. At the same time, because of this anxiety and the epistaxis going on, patient's blood pressure would also be high. So we cannot conclude at this point.
Okay. So suppose if this patient is a non-hypertensive and we find this BP to be very high, we can give any antihypertensive drugs. And along with that, this patient might be anxious seeing this blood. So first we should give one anxiolytic. So
at this time, we can try with going with midazolam because the patient's respiratory status is quite fine, airway is patent, so we can.
But midazolam, if we give, the patient will sleep. No, we don't know.
Half dose.
We can give any oral anxiolytic agents like what can we give? Any anxiolytic, any Ancet or something can be given. No, if we give midazolam, patient will sleep up. So give one short anxiolytic agent.
Okay. Beta blocker.
Let the anxiety come down, then we will plan on controlling the heart rate and BP. Okay. And you made the patient sit like this. So how should we ask the patient to
lean forward and pinch the septal area, basically ask him to pinch it tightly the septal area so that the bleed will stop, and we should refrain him to like continuously keep checking whether did it stop or not.
So how
Continuous
much time
pressure,
he should pinch the nose? Which part of the nose should be pinched?
the cartilaginous
The cartilaginous or the fleshy part.
fleshy
The
part.
bony part shouldn't be pinched. So the fleshy part should be pinched. And how should he place? He should actually sit straight, but head should be leaned
Leaning
forward. And he shouldn't lean completely forward. Only the head should be forward. And what if the blood is coming through the nose? What should he do? He should pinch it completely, and suppose if he is feeling the blood is coming, he should spit out the blood. He shouldn't open the nose and again bring the blood out. He should spit out the blood. Okay, so how much time should we keep him like this? Maximum 10 to 15 minutes. Okay, even after 10 to 15 minutes this is not working, then we'll have to plan on the next one. Okay, so for this patient, you don't have to use the soaked gauze and all initially. First we can ask the patient to pinch it like that. Then if it is not working, only we will be planning on the other things. Okay.
Continuing with the primary survey, ma'am. The next part, disability wise, patients GCS was full E4, V5, M6, bilateral pupil 2 mm and reactive, symmetry, bilaterally symmetry. Exposure wise, temperature is afebrile, hypothermia was prevented, ma'am. And GRBS of the patient was 85. So we asked to take the oral food intake. At this point, he is not in a position to take as it's bleeding.
No, this is not hypoglycemia, no, then why should we ask him to take food?
85 and lower.
No, 85 is not on the lower side. What is hypoglycemia in adults?
Below 60.
GRBS less than 60. In case of children and neonates? Neonates is no, less than 45. Less than 45. Okay.
Rest other adjuncts to the primary survey were done. Hemoglobin was 11, no significant drop of the bleeding as per the bleeding wise. Rest all investigations are within the normal limits, lactate points.
So by the time you took the ECG, heart rate became 79. So he is out of anxiety, I think. And he is already having LVH features. So he might be having, he's a long-term hypertensive. Okay. Why was able to take it is not required. Okay.
Basically,
secondary survey, sample history?
Secondary sample history wise, patient is a known case of systemic hypertension, old CVI 5 years ago with having left hemiplegia and CKD stage 4.
Okay.
And basically he's on multiple antihypertensives for the last 3 years. Right now, the morning dose, he had skipped 2 of his medications, and the previous night, like the episodic history is yesterday night he had nasal bleed. He was not sure which side, right or the left, but from both nostrils there was nasal bleed. When he had washed his nose and when he had pinched his nose, it stopped bleeding. So he went to sleep. In the morning, when he awoke, when he was brushing his teeth again, from the right, specifically from the right nostril, there was bleeding present. So he came to the emergency immediately.
Okay. Is he on any? So he is a dialysis patient and he is having many comobs. So what drug history we should be asked specifically?
He has specifically any antiplatelet. As he is an old case of CVA, he was on ecosprin and clopidogrel.
Okay, so he is on antiplatelet. Then?
And antiplatelets, history wise, and his BP.
He is CKD on dialysis. So what will be
BP?
No, CKD on dialysis, what can attribute to the bleed? He might be having, he's on dialysis, no? He might be on heparin dialysis. Okay. So suppose if a patient is taking antiplatelet and patient comes with bleed, how will we reverse it? We have no way to reverse it. Okay. So suppose this patient is on, came with epistaxis immediately after dialysis. How can we reverse the heparin effect?
Heparin induced by giving sulfate.
What sulfate? Protamine sulfate.
Sulfate.
Protamine sulfate. How much should we give? Protamine sulfate we should give. If we give 1 mg, then it can neutralize up to 100 units of heparin. Okay. So heparin, if we want to know whether it is because of heparin, the bleeding is because of heparin, what blood investigation should we do? APTT. Okay. Then suppose if this patient is taking, what is heparin?
Heparin is a thrombin and factor 10 inhibitor, 2 and 10.
It is indirect 10A inhibitor. 10A inhibitor. Okay. Then what is direct 10A inhibitors? Dabigatran. Dabigatran is 2A inhibitor. This is dabigatran. 10A inhibitor is this apixaban, rivaroxaban, these things. So if this patient is taking some 10A inhibitors, how will we reverse?
Giving the FFPs which has clotting factors.
No, we will have to give the reversal agent. That is Andix and alpha. Andix and alpha should be given. If this patient is on dabigatran, what we should give? Dabigatran, we will have to give praxibind, or we will have to give idarucizumab. Idarucizumab, that should be given. Suppose this patient is on vitamin K. Warfarin. What will we do?
We can give vitamin K and FFPs to reverse.
Okay. If he is on vitamin K, warfarin, we will have to give vitamin K. Okay. But vitamin K will take 3 days to act.
Yes,
so a patient is bleeding. What will we do? And how will we know the patient is in coagulopathy? With what blood test? INR.
Warfarin
INR. Okay. So INR should be checked. Warfarin patients on this thing, INR is elevated. So how will we reverse it? We have only vitamin K to reverse, but vitamin K will take time to reverse. So what else can be given instead of? Fresh frozen plasma is there, but it's not specific. We can give 4-factor PCC. What is PCC? Prothrombin complex concentrate.
The 2, 7, 9, 10
specific concentrate we will have to give. Okay. So this is how we will be reversing if it is epistaxis secondary to the drugs. Okay. Was APTT checked for this patient?
No.
Okay.
Only primary type.
Okay, so we will have to, so in this patient we will have to check, give anxiolytic, and immediately along the blood investigation, hemoglobin, platelet and all, we will have to check the APTT also. Okay.
Regarding the pathway of this epistaxis, as when we receive a patient in our emergency with epistaxis, first thing we do is the ABC. If the patient is stable, then we will make the patient follow the Trotter's method.
Okay.
Trotter's method, if the bleeding stops then and there, we can discharge the patient. If the patient is still bleeding, then we will be advised to go with the rhinoscopy and find the source of the bleed, from where it is.
In this patient, will you be able to discharge with this much high BP?
No.
Unevaluated APTT? No. So suppose if you are planning to discharge a stable patient, like some nose picking or something, or if you are planning to discharge, how will we discharge?
After confirming the patient.
No. If it is a very stable patient, we want to discharge. Before discharging, we'll have to, that we'll discuss later. Okay, fine. Now continue.
So if the bleeding is still persisting in such cases, we find the source of the bleeding point and we can try with the chemical cautery of silver nitrate. If even the first thing is silver cautery, silver nitrate, if we can't find the source of the bleed.
How will we give silver nitrate?
Application of the
with a stick. It will be there. So what is the contraindication of giving silver nitrate?
We should not give bilateral. If you give bilateral, ischemia of the septum can be the
occur. Okay. So silver nitrate cautery. So first we will. Okay. Okay. So okay, you did that. You did the nasal cautery. Then third.
If that is also, when we find the source of the bleeding point. If you are not finding the source of the bleeding point, we go with the tamponade techniques of using Merocil. And
so before tamponade, we can do one more thing. We can use a gauze with adrenaline. Adrenaline, how much?
1:10,000.
1:10,000 adrenaline plus 4% lignocaine. We can apply. Gauze can be applied for 10 to 15 minutes. So 10 to 15 minutes, what all? Trotter's position can be tried. Then the other thing is the
Ice packs
nasal
also
cautery.
can be put across near the nose and everything to cause vasoconstriction.
Ice packs, if we are keeping over the bridge of the nose, it can cause vasoconstriction, but there is no point in keeping all over the face, head, and all. That has no effect. Okay. So we can use this nasal packing can be done, or this can be kept only after 10 to 15 minutes. And after that, if it is not working, then we'll have to plan on nasal tamponades. Okay.
In nasal tamponades, like first is the Merosil, but in the Merosil, this kind of items, when you put it, it should be placed for 24 to 48 hours. It should not be removed immediately. Like
how will you place Merosil?
With the help of nasal forceps, we will put it.
Merosil is coming something like this.
Yes.
Some flat thing.
Yes.
If you directly place onto patient's body, patient's nostril, will he have pain?
Saline.
No, we will have to use something like bacitracin ointment or some ointment should we use. Gel or nasal saline we won't be using initially. First we will be using some ointment. We will be lubricating it. Before that, if at all we have given some adrenaline packing and all, patient will be already, that area will already anesthetized. Otherwise we will have to anesthetize and then we will have to insert it using that bacitracin ointment. And after inserting it inside, what should we do?
With
this is a flat thing.
Yes,
this is a flat thing.
We should push 10 to 15 ml of saline
into it, so that it will expand. Okay.
And it will cause tamponade. And we should only do it one side. If bilaterally also having only one side, we can use this tamponade, this kind of technique.
Actually, you can do bilaterally. Okay.
That's it. Even if after doing the tamponade techniques, even if still it's persisting, then we'll go to a.
So that is one technique of tamponade. Other technique?
Other techniques would be there is this Foley's type balloons. Which
what is that? Rapid rhino. How does that work?
By pushing the air, that the bulb will expand and it will.
First, we should insert this thing inside the nasal cavity, like this, through the base of the nasal cavity. This thing we will have to insert, and we will have to push air. How much air?
5 to 10.
20 ml. 20 ml air should be pushed inside. Okay, that is how rapid rhino works. Okay, then third one. Then we can pack with ribbon gauzes. Ribbon gauzes you have seen, you might be seen in your MBBS days, no? The ribbon gauze, that long thing will be there. Ribbon gauze will be somewhere coming as almost 180 centimeter long ribbon gauze will be there. So with that we will be packing, and each time we will be taking 10 centimeters and we will be pushing it inside. So this can be, it should be used with bismuth. This thing. Okay. So there are 3 ways of creating tamponade. Okay.
Even after tamponade, if still the bleeding is persistent, then we can expect it might be coming from the posterior circulation, for which we will use a technique where the Foley's tube is used, where tip is cut, and we pass it on through the nostrils, and when it goes towards the posterior to the nares, there we inflate the Foley balloon to create the tamponade effect on the posterior side. And even like after that also still bleeding is continuing, then we would be expecting to do a surgical maneuvers like embolization or resection of the artery there.
Other techniques in the algorithm like gel and forms and can also be used. Okay.
That is
okay. Then how will we discharge this patient? So we had a patient with epistaxis. We somehow managed. We have placed a Merosil on this side and bleeding has stopped. So how will we discharge? With what advice we will discharge?
When within the first 48 hours, there is no recommendation of any antibiotics. But even after 48 hours, if bleeding is persistent, then prophylactic antibiotics is advised.
What antibiotic?
The augmentin covering this.
We can give creams. Like we can give either a mupirocin cream can be given. Mupirocin. We don't want, because blood is a good medium, right? So mupirocin can be given. Can be given thrice a day for 5 days. Then, or we can give some ointments like neomycin with chlorhexidine. Chlorhexidine can be given twice a day for 10 days. So that also should be kept in mind. Otherwise, that can cause infection. Okay.
Apart from that, the basic reason of the epistaxis also should be evaluated if it is by any physical trauma or such, that treating that would like covering up if there's any abrasion, laceration as in trauma cases, that is required to evaluate if there is any nasal bone fracture or any other causes.
Do you have the photo of the blood supply of the nasal septum?
Basically, this blood supply of the nose is actually an anastomosis point of both internal carotid and the external carotid artery. Both the anterior and posterior ethmoidal arteries come from the ophthalmic artery of the division of the internal carotid artery, whereas external carotid artery branches are the greater palatine artery and sphenopalatine artery and the superior labial artery. In the anterior, this Little's area in the Kesselbach plexus, it's the anastomosis of the superior labial artery, greater palatine artery, and anterior ethmoidal artery.
So this much is branch of internal carotid artery.
I see. Yeah. These three are branches of the maxillary artery and the indirectly branch of external carotid artery.
Okay. So this is what you are marked here is the Little's area. It is not there. Almost like this is the Little's area. Okay. And here, somewhat here it is the...
These both, posterior ethmoidal and the sphenopalatine artery would be the
Woodruff's plexus. Okay.
This would cause that bilateral epistaxis, and this usually causes unilateral epistaxis.
Okay. Any pictures? Anything else? Nothing. Okay. What happened? How did this patient improve?
This patient has finally, on prolonged evaluation, her BP was constantly high even after controlling the bleed. So the cause of reason would have been an accelerated hypertension, which then, as she's a patient of CKD stage 4, we started on NTG infusion for a day and slightly titrated it, and we increased the oral antihypertension medication. And finally, like nephrology had admitted the patient, observed her for a few days, and discharged it.
Okay. How did the bleeding stop?
Bleeding stopped with the Merocil
packet. Okay. Fine. Thank you.